Hello and welcome to HD Live. I'm Mabel Jong. The American Heart Association Scientific Sessions 2020 just wrapped up and covered everything from COVID-19 and its impact on the heart to a 5-step strategy to address structural racism as a driver of health disparities. For some key takeaways and highlights from the conference, I'm so pleased to welcome Dr. Donald Lloyd-Jones, American Heart Association President-elect and Chair of the AHA Committee on Scientific Sessions Programming. Thanks for joining us, Dr. Lloyd-Jones. Great to see you today.
Thanks, Ms. Jong. It's great to be with you.
Well, you covered a lot of ground during this meeting. What do you feel were the most impactful takeaways?
Well, as you mentioned, this was an entirely new format for us, all virtual. And I think we learned a lot about how to do a virtual meeting, which was pretty exciting. It allows people from really all over the globe to interact and engage in the presentation of science. I think that's a very exciting, very democratizing process. And so, while we all love our in-person meetings when the science is presented, I think there are real benefits to this virtual format. And going forward, we're likely to see hybrids. Some of the exciting science and themes that I think we saw at this year's meeting included some very new, fresh takes on prevention. So new looks at fish oil, and is it really as beneficial as we think it is, or is it just about the formulation? A new first of its kind international outcomes trial using a polypill formulation that showed benefit in reducing risk, maybe even with aspirin as well. Some new therapies for heart failure, including a first of its kind cardiac contractility increaser, something that improves the contractility of the heart and doesn't kill patients and actually improves outcomes. And then iron therapy, intravenous iron therapy for hospitalized heart patients showing benefit as well. But I think another thing that was really exciting was a number of small but very well designed studies and trials that gave us insights into particularly vexing clinical problems like MINOCA, heart attacks with no obstructive coronary disease, particularly problematic for women. A new drug for recurrent pericarditis, which is a really tough problem to treat for both patients and clinicians. And then a very, very well-designed study to try to understand what is it that causes side effects in patients who are intolerant of statins. And then, as you mentioned, of course, lots of science around COVID-19. How could we not? And then some very important areas of focus on structural racism and health equity. So all in all, really exciting meetings, lots of science to share, and I'm happy to visit with you about it.
Oh, right. You covered so much. You mentioned, of course, COVID-19 being the subject of many, many different conferences this year. You have a greater understanding of COVID-19 and additional risks when combined with an irregular heartbeat. Could you elaborate on that?
Yeah, so we had a number of sessions that focused on COVID-19, and really proud of the American Heart Association very early in the pandemic pivoting to both fund new discovery science about why COVID-19 is as severe as it can be and why it affects the cardiovascular system. So a number of grants that were actually funded just in the beginning of May already reporting results, giving us insights into, as you mentioned, why there might be increased risk for arrhythmias. The virus actually gets in, and one of my colleagues put it nicely, kind of opens all the windows of the cell and lets other toxins and other things into the cell that increase perhaps the irritability of the heart. Also, evidence that there are certain forms of inflammation, maybe not so much myocarditis, direct infection of the heart cell, but actually inflammation at the vascular border that is driving some of the myocardial damage, and also a lot of the microthrombi, those little blood clots that we're seeing throughout the body as a result of this infection. We also saw some really interesting data from a large registry that AHA started again very early in the pandemic, already reporting results on 20,000 patients, and again, giving us some insight into risk factors, particularly obesity as a risk factor for severe infection, and also race ethnic differences in outcomes with COVID as well.
Okay, now to get back to, you talked about diagnostic imaging, which has been found to help identify the cause of heart attacks in women who did not have a history of blocked arteries. What did you learn about that, and what was presented, and when might additional imaging exams be ordered in those cases?
Yeah, this is a very well-designed study. It was a smaller study of only 200 women, But they took these women who had presented with heart attack, so they had symptoms, many had EKG changes, they all had elevations in their troponin, heart biomarkers. So met the definition of heart attack, taken to the cath lab, no obstructive coronary artery disease. That's what MINOCA means. So in the past, I think we often scratched our heads, probably too many women, who are the people who tend to present with this problem, too many women sent home just with a shrug and saying, we're not really sure why. Well, what they did was they systematically did OCT. They looked down the coronary arteries specifically, rather than with a standard angiogram, they actually looked for different types of plaque. And then they also took them and did a cardiac MR to look for evidence of myocarditis or any other damage. So really trying to get to an answer in these women with this type of heart attack, where in the past we haven't really known what the answer is. Really important finding. They were able to make a diagnosis in 85+% of these women. And in fact, in the vast majority, it was good old-fashioned atherosclerosis. It was plaques. They looked a little different in these women, but it was atherosclerosis. And then in a minority, about 20% or so, another explanation such as myocarditis or Takotsubo cardiomyopathy. So what it suggests to me is that we should be treating essentially all of these women as if they've had an atherosclerosis-based heart attack, unless proven otherwise, like something such as myocarditis.
You also took a look, or one group of scientists took a look at the use of omega-3 fatty acids and vitamin D3 supplements, but then also revealed that they did not increase nor decrease the risk for incidental atrial fibrillation according to their 5-year studies on this. Yeah. What implications does this hold for the continued use of these supplements?
Yeah, so 3 large trials actually. The one you mentioned, which looked at a fish oil combination low dose or vitamin D in attempting to prevent the onset of atrial fibrillation, no effect, no benefit, whether it was the fish oil or the vitamin D. So a wash there. 2 other large trials using fish oil combinations at moderate or high dose, trying to prevent major cardiovascular events, heart attacks and strokes. Neither of those showed benefit. In fact, in those studies, though, we saw an increased risk of atrial fibrillation. So a lot of buzz about these trials. Fish oil does not seem to be very beneficial, with one exception. 2 years ago, we had a trial called Reduce It, with a very high dose of a specific compound, an enriched EPA compound, a certain type of fish oil. That showed a pretty striking benefit, and we're not sure exactly what the difference is between that trial 2 years ago and these trials today that didn't show benefit, but it may have to do with the compound, it may have to do with the dose of fish oil, and it may have to do with what we're comparing that to, the placebo group in this, where there have been important differences in the trials. So lots of conversations going on, and we need more information.
There was a call to action during the meeting to address structural racism as a driver of health disparities. What is the association's effort to stamp out racial inequalities in heart disease incidence?
Yeah, so obviously the events of 2020 with COVID have uncovered tremendous health disparities in this country. Communities of color, rural communities, having much worse outcomes than sort of the majority population. These things aren't new, but they've certainly been brought to the fore by the COVID epidemic. And in response to that, and particularly the other events of 2020 with police killings and other things, I think structural racism is now a topic that we all need to be more aware of. I'm really proud of the Heart Association in publishing the statement you alluded to, addressing structural racism as a major driver of health disparities. And in that statement, the authors actually look at what's the history of structural racism, how is it different from individual racism? These are things that are built into policies, built into society, that disadvantage certain communities and certain people. And the Heart Association has looked carefully at how that structural racism affects health through things like education, through things like opportunity, and of course, access to healthcare. So many different ways that it can affect health. And then the Heart Association provides a call to action, a pledge, if you will, that we're going to be conveners, we're going to be advocates, and we're going to be an important force for trying to disrupt structural racism and improve health equity across our systems.
Okay, there was a 5-step plan. Could you talk a little bit about that?
Yeah, well, I think a number of features of that include we need to start by looking inward at the Heart Association and understanding how any policies or procedures or historical approaches have actually tried, helped to embed or further structural racism. And we're completing that process. I think it's very important for all of us to look inward. But then we're also going to look outward, and we're going to try to understand how our research programs, the American Heart Association funds somewhere between $100 and $200 million in cardiovascular research every year. We want to make sure those research programs are designed in such a way that they reflect the diversity that's needed so that we get important answers across the spectrum, and that we develop new programs that can also, again, drive to greater health equity across all of our systems. We need to think about our advocacy. The American Heart Association has a very strong voice, a strong brand. People know us and trust us, and we need to use that power to get better policies in place so that everyone has an equal chance at a longer, healthier life. A number of other things that are outlined here, but they basically all drive to the same thing. The AHA can't do this alone. We have many partners, and we can convene many other actors who can try to, again, combat structural racism throughout.
Is there a general equation in terms of what the impact is on care when some neighborhoods don't have the same access to resources when it comes to caring for heart disease? If they don't have the same resources in some neighborhoods as others that have access to the best care possible?
Yeah, I think some of the most striking data that I've seen about that in recent years are just simple longevity data. What is the average life expectancy in a community? And right here in Chicago, where I live, there's an 8-mile difference between our lowest life expectancy and highest life expectancy community within the city of Chicago. 8 miles, 17-year difference in life expectancy. And if you look at the things that are different about those communities, it is entirely about safe streets and whether you can go out and actually participate in physical activity, access to healthy foods, access to a stable health system where you can actually get preventive care and not just an emergency room. So many other things that really drive to these social determinants of health. And your zip code shouldn't determine your life expectancy. That's just not right. It's not fair. And so we need to really level set, get much better understanding the structures that are in place that create these disparities, knock them down, and really have a fair and equal opportunity for everybody.
Okay. What are the plans for the next sessions that will meet next year, Dr. Lloyd-Jones? Have you put in place some of the other studies that will be focused on?
Well, so scientific sessions for the American Heart Association in 2021 will be in November 13th through 15th in Boston. We're very much looking forward to being back to an in-person meeting, at least in part. Although, as we mentioned, I think some of this will be hybrid, that there will be on-demand and pre-recorded and full access to some of the science. We are actually starting, we're a day after AHA Sessions 2020. We're already starting to design Sessions 2021. So lots on the table, much on the drawing board. But I think what you will see is a major new focus on long-term COVID. What are the long-term impacts, particularly on the cardiovascular system? Continue to see novel therapeutics, new drugs that are going to be treating heart failure and other conditions. And then again, I think we're going to continue to see a real focus on AHA-funded science that is trying to drive towards health equity.
All right, Dr. Donald Lloyd-Jones, thank you so much for your time today. Really appreciate it.
It's great to be with you. Thank you.
And that was Dr. Donald Lloyd-Jones, American Heart Association President-elect and Chair of the AHA Committee on Scientific Sessions Programming. And thank you for joining us for this session of HD Live, the streaming video service of Health Day News. For more health news, remember to check us out at live.healthday.com, on our Facebook page at Health Day News, and on Twitter at Health Day Tweets. I'm Mabel Jong. Have a safe and healthy day.